I think this is where we left off. Does that look right?
No, skip way ahead to where it says cryotherapy. There you go. So this is the second half of a presentation that talks about minimally invasive pain treatments. And the first part was discussing two new procedures that we're going to do here or are doing here for spinal stenosis that either delays or eliminates the need for larger laminectomies and other types of bigger surgical procedures. Now we're going to get into two of the older methods that we use and still use today. And the first one is cryoablation. Next. So this is what it is you would expect. Use of extreme cold to destroy tissue, particularly nerves. The machine we have uses two gases. One gas heats up when it expands, and one gas cools when it expands. So we cool the tissue, and then we heat the tissue up. The heating of the tissue causes the cell to lyse, and then the nerve dies back, and as it grows back, the patient has pain relief. We can vary the size of the lesion. Cryotherapy has less of a chance of deafferentation rather than heat or radiofrequency, which we're going to talk about, and this is usable with other electronic devices in the patient. So if you have a pacemaker, AICD, spinal cord stimulator, anything that has a battery or a lead, you have to stay away from diathermy. And technically what we do when we do radiofrequency, most peripheral nerves, we can do the face, neck, nerves. We're going to talk about some indications later, but almost any peripheral nerve that doesn't have motor component is in play. Next, please. This is what the machine looks like. There are cryoprobes that hook into the side and the gas tanks on the other side, and this machine modulates the gas flow, and it is programmable so that when they set it all up, they push Vaglienti and it runs through a cycle that we want. Next. So these are the things we use it for the most. Tension headache after you've had greater or lesser occipital nerve blocks, and they may not have lasted but have given good relief. We can go cryoablate them, and we trade a numb skin of the head for pain. This has been very effective. Some of our patients have had relief up to a year out. Scar neuromas almost anywhere on the body. The most common are from inguinal hernia repair with mesh. That mesh was designed to facilitate scar formation so that the hernia is closed. And that area is served by either the genitofemoral or the ilioinguinal nerve. So we first inject it, try to figure out which nerve it is and where we're going to approach it, and then we can freeze it. Post-thoracotomy, post-mastectomy, post-herpetic neuralgia, we can get via the intercostal nerves or with direct local treatment of any scar neuroma once we localize it and identify it. Next, please. And now we go on to radiofrequency ablation. Next. This is simply the opposite. So cold versus heat. That's the only difference, the same idea. This is our go-to procedure for low back, neck, and now for knee pain. So some of you may be interested in that. Patients who have chronic knee pain who are not joint replacement candidates or who have persistent pain after joint replacement, or now we have a new indication we're using, and that is patients who have knee pain and are being optimized for surgery. We can do this procedure and so that they can do what's necessary to get their A1C in line, get their body mass index in line, those kind of things, because they'll always come back and say, well, I'd like to lose weight, or I know I have to lose weight, but I can't exercise. So we can help them with that. Next. This is the machine, what it looks like. Obviously, the blue part is a grounding pad. It can do up to 4 lesions at a time. And the needle placement is done under fluoroscopic guidance in all cases. Next, please. biggest use we have is axial neck and back pain. And that's when we do what are called medial branch blocks. And we numb the facet joints in any part of the cervical, thoracic, or lumbar spine. After we do those injections, you come back and tell us if it helped. If it helped, but it didn't last, we repeat that injection. And then we, after that, go to radiofrequency. These procedures generally last 6 months, sometimes more. We also use them after sympathetic nerve blocks that have good result but short duration. And so this has been used in the past for stellate ganglion blocks, for facial pain, and for lumbar sympathetic blocks for lower extremity pain. Next, please. This is the knee procedure. So 3 probes are placed around the knee, 2 above and 1 below. We avoid the fibular side because the perineal nerve is there. We're blocking the genicular nerves, and these are the these are actually a different type of radiofrequency probe, but the positioning is identical. Next. That's it for this time. Any questions?
Wonderful, thank you.
Sorry. Are we there? Okay. Just thinking about, have you attempted this kind of procedure with anybody who has peripheral neuropathy pain? Because I'm seeing patients whose foot pain, in my case from chemotherapy, is really inhibiting their ability to exercise and get back to function, and really stymied with stuff to do with that.
Well, we have a lot of things we can do with it. In fact, that's one of my areas of interest. So we have spinal cord stimulation, and we have a medication called Prealt, which we give intrathecally, which can take care of these neuropathies. Chemotherapy neuropathy is different than other neuropathies because its causation and the way you treat it is completely different than other peripheral neuropathies. But we see this a lot, and sometimes, unfortunately, oncologists, once you have your tumor either treated or controlled, they really don't think much of the rest of the symptoms.
Yep.
And so, you know, yeah, we can help with that, but not with these procedures.
Okay. Good to know.
Thank you again. That was wonderful. Any other questions? Like I said, we don't have a traditional case prepared for today. I don't know if we said, but we're joining from Cabin Creek, so we're down in Charleston right now. So that's why it's different. Dr. Vaglianti, do you remember the patient that Dr. Peters was talking about a couple of weeks ago? Would this at all be something that would be helpful? I know that he had a weight problem.
Oh yeah, that patient was probably out of bounds for everything. And I think we came to the conclusion that gastric bypass or something like that was more in order. Yeah, we talked about this a little bit. He would have to go somewhere where he could get in a pool and exercise with some decompression of his joints and spine. But no, this probably wouldn't benefit because he would just burn through it.
Gotcha. I understand. All right, guys. Anything else? Any questions? You're good. I'm good. But that was awesome. Great. I'll see you guys in 2 weeks. I'll be in touch. Let me know if anything comes up. I will have the hub calendar sent out to you guys, but I'm also going to release it to everybody so they can start planning cases related to those topics we talked about. All right. Everybody have a wonderful day. Stay warm. Bye.